Welcome to Georgia Southern University, Jiann-Ping College of Public Health, the Department of Biostatistics, Epidemiology, and Environmental Health Sciences. Today, we are very honored to have Dr. Kwok, Assistant Professor in the Jockey Club School of Public Health and Primary Care at the Chinese University of Hong Kong. Today, Dr. Kwok is going to present to us his work on the likelihood of COVID-19 vaccination among primary school students in Hong Kong. So without further ado, welcome, Dr. Kwok.
Thank you, Isaac, for your nice introduction. So before I start with my recent published work, I would like to give you some background of this study. So almost 1.5 years after the pandemic declarations of the coronavirus 2019 by the WHO, the outbreak, which initially began in the city of Wuhan, has affected more than 200 populations, resulting in more than 200 million reported cases and 5 million deaths globally. And early insights from countries such as Israel, UK, with high vaccine uptake, offer the hope that the mass vaccination can bring an end of the pandemic. So currently, almost half of the world population has already received at least one dose of a COVID-19 vaccine, and 6.6 million doses have been administered globally, and 23.17 million are now administered each day. However, according to the United Nations, vaccine inequity will still have a lasting impact on socioeconomic recovery in low and lower middle income countries, because right now only 2.5% of people in these low income countries have received at least one dose of a COVID-19 vaccine. So in 2020, while a lot of scientists tried to develop COVID-19 vaccine, many epidemiologists were very interested in what can we learn from the previous pandemic, because as an epidemiologist, I am also very interested the way to end the epidemic. So that's why a lot of literature related to 1918 flu experience tell us possibly if we are able to achieve the so-called herd immunity level, the pandemic will end. So what's the concept of the herd immunity? So maybe some recap. The concept of herd or population immunity relies on a large majority of a population gaining immunity, either through vaccinations or previous infection, which in turn provides indirect protection from an infectious disease for the unvaccinated and those who have never been previously infected. So you can see from the diagram on your right, at the very beginning, the first one, the blue man represents healthy, not immune individuals. And because some of the individuals are infectious, that's why without vaccine, without any immunity on some of the individuals, the virus can be spread effectively to many people. After some time, due to some individuals get infected, they have they gain the immunity due to the natural infections. That's why you can see in the second part of this diagram here, you see some gray people here, they get immune because they recover from an infection. Recently, due to the development of COVID-19 vaccine, that's why some people can be immune after vaccination. That's why currently the situation is something like that. It's the last diagram here on the right. At that moment, a lot of epidemiologists are interested in what proportion of the population we need to vaccinate or be infected to achieve the herd immunity against COVID-19. We expect this threshold is likely to halt the spread of the virus and the COVID-19 pandemic will end. According to some formula that I think most of you may be very familiarized, given the basic reproductive number, which is a number of secondary cases infected by one case on the average in a totally susceptible population, we can base on this basic reproductive number estimate and calculate the corresponding threshold of the herd immunity achievement, which is 67%. That means if 67% of individuals have immunity, the pandemic is likely to end. Unless and until we reach this threshold, we will not be certain of protection against the epidemic locally and around the world. It's also, and also the value of the vaccination is it needs to be achieved as quickly as possible, given the emergence of the SARS coronavirus 2 variants, which may be resistant to existing vaccine, rendering them less efficacious. However, recently, we noticed that there is a highly transmissible Delta variant, which emerged in more than 1,000 population. And majority of current vaccines have lower efficacy rates against these Delta variants than the original virus or previous Alpha variants. And many of the original parameters for achieving immunity have gone out of the window with this COVID-19 Delta variant. Vaccination does not stop a fully vaccinated person from being infected by the Delta and ongoing transmission. I think a lot of you may heard about the idea of the breakthrough infection. That means even you get vaccinated with no matter CoronaVac or Sinovac or Johnson & Johnson or Pfizer vaccine, you still notice that fully vaccinated person are still able to be infected by this Delta variant, and also these people are able to transmit the disease to other vulnerable individuals. So in other words, the Delta variant will still infect people who have been vaccinated, and that does mean that anyone who's still unvaccinated at some point will meet the virus, and we don't have anything that we completely stop the transmission. So luckily, vaccine is still able to protect the individuals from severe infection and mortality. Okay. However, the vaccines no longer stop the spread of the COVID-19, and meaning that reaching the threshold for overall immunity in the populations becomes elusive. So that means there is something that we do not expect. We expect we are able to achieve the herd immunity. We are able to by natural infection and also the vaccination. Ultimately, this herd immunity equation is changed from time to time due to the emergence of the new variants. As I said before, there are still value for the vaccination because we expect vaccination is highly effective at reducing severe illness and deaths from COVID-19. And the reason behind is so COVID-19 has a much higher mortality rate than influenza. So that's why we expect in the medium term, COVID-19 will likely become kind of an influenza if we are able to reduce the case fertility rate as influenza via the vaccination. So that's why the value of vaccination is to get COVID-19 becomes influenza-like respiratory disease. So you can see from the recent study about the in-hospital mortality was higher in patients with COVID-19 than in patients with influenza, with a relative risk of death of 2.9 and an age standardized mortality ratio of 2.82. And you can see the mortality rate of COVID-19 was reduced through vaccinations. So this is the data from the UK Office of National Statistics. You can see this table shows the attendance of emergency care and deaths of confirmed and provisional Delta cases in England by vaccination status from February 2021 up to August 2021. So may I draw your attention to the rectangle, the red rectangle showing the number of Delta cases of age group individuals greater or equal to 50. Okay, so you will see about 21,472 individuals had received 2 doses of vaccine. Okay, among them, 389 died from COVID-19. So you can also refer to the last column. Another number is 3,440 who were unvaccinated, and ultimately 205 of them died from the disease. So when you do some simple calculation on the case fertility rate, so the case fertility rate is the number of deaths out of number of cases. So when you compare the CFR for 2 groups, the case fertility rates for 2 groups, vaccinated groups and unvaccinated groups, the percentage for the fully vaccinated person is 1.8%, while the unvaccinated group CFR is 6%. So based on these 2 percentage, you can see how the mortality rates of COVID-19 was reduced through vaccination in the UK. Okay. So when you refer to another diagram, you will see almost half of the daily infection in the UK are currently being recorded in children aged under 19 years old. So another diagram, you will also see in 5 to 9 years old, COVID-19 case rates have never been as high as they are now, because right now children are the most susceptible group to infection. In the UK, less than 10% of under 18s have had 1 vaccine dose, and children are the most exposed to infection with high number of close contacts with their classmates in school. And also right now in school, there were minimum restriction applied in school to mitigate the spread of the disease. For example, the removal of mask mandate. So there's another diagram showing hospital admission rises in under 18s in the recent months. It seems to us that the age profile of becoming severely ill has shifted downwards. As I said before, you will see vaccinations seem to be an effective approach in reducing mortality and also severe infection. However, right now, the minimum age for the vaccination, for example, in Hong Kong, is 12 or above. The minimum age is still 12 years old. So recently, Pfizer announced in a tweet that it had formally filed its application with the FDA. As far as I know, from the newspaper, it's likely to allow the kids to be vaccinated in the coming months. Okay. However, there are lots of concerns from the parents about COVID-19 vaccinations. So that's why I would like to give you some idea about the vaccine hesitancy. Vaccine hesitancy is not a new term, especially for the parents. What is vaccine hesitancy? The World Health Organization defines vaccine hesitancy as a delay in acceptance or refusal of safe vaccines despite availability of vaccine services. It is caused by complex context-specific factors that vary across time, place, and different vaccine, and is influenced by issues such as complacency, convenience, confidence, as well as socio-demographic context. When you refer to the top 10 global threats to health listed by WHO, vaccine hesitancy is one of the top 10 issues to health in 2019. In addition, the term vaccine hesitancy, although widely used, may not adequately convey these wider determinants influencing decisions to delay or refuse vaccination. So as I mentioned before, we have some construct to illustrate the cause of the vaccine hesitancy. The Strategic Advisory Group of Experts on Immunization, SAGE, from WHO and academic researchers devised the 5C. You can see from this diagram, we have 5 words starting from the capital letter C. We call this 5C, psychological antecedents of vaccinations. The first one is confidence, which is the trust in the safety and effectiveness of vaccine. The second C is complacency, which refers to not perceiving the disease as high risk. So imagine talking about 1 year ago when a lot of cases were identified in the community. A lot of the individuals will perceive the disease as a high risk because a lot of infections were identified in the community. So in Hong Kong, because everything seems to be well controlled in the past 18 months, in total, including imported cases, we had only 11,000 infections in Hong Kong. So that's why in most of the time, we perceive the disease as a low risk because we can't find a lot of cases in the community. Of course, imagine the situation in India, talking about 5 to 6 months ago. A lot of infection die from the disease. They will definitely perceive the disease as a high risk. So different countries' citizens may have different perception on the disease, whether it is high risk or not. Sometimes it's very influenced by the number of infection in the community. The third one is a constraint. Constraint is referring to the barriers to vaccination, such as availability. So imagine if you it's quite difficult for you to get access to the COVID-19 vaccine. That means that you have a high constraint to the vaccinations. The fourth C is calculation. Calculation is referring to the engagement in extensive information searching. The last one, collective responsibility. That means willingness to protect others through the herd immunity. So in the recent months, we also published another paper to look at the vaccine hesitancy of the general population in Hong Kong. So we also identified that confidence in the importance, safety, and effectiveness of vaccine has the strongest association with vaccine uptake. So you may probably ask me why we have cause of vaccine hesitancy. There are a couple of factors, including socioeconomic and healthcare inequalities. The second one is a structural racism and previously unethical research involving some ethnic minority groups. The third one is social disadvantages, including low levels of education and poor access to accurate information. Misinformation, disinformation, rumors, and conspiracy theories, in particular in the social media such as Facebook, Twitter, can also be one of the reasons for the vaccine hesitancy. And lack of effective public health messages or targeted campaigns, and also barriers to access, including vaccine delivery time, location, and cost related to socioeconomic inequalities and marginalization could be the cause of the vaccine hesitancy. So in early 2021, when the vaccine rolls out, this is the survey for many affected countries in the world. You will see a lot of countries also face the vaccine hesitancy. For example, Russia, you see the percentage to agree to get the vaccine is 40-something%. Of course, you can also see some countries have a very high percentage. For example, Italy, South Korea, and also you can also see from this diagram showing the percentage change in the percentage strongly agree. So at the very beginning, a lot of countries also face the problems of the vaccine hesitancy. So how about Hong Kong? What's the situation in Hong Kong? You will see we did a survey before the vaccine rollout to check whether they have intention. Okay, at the times of the survey, the vaccination is not ready yet. We had a survey to examine the intention to receive COVID-19 vaccine. We can see there was a decrease significantly from the very beginning, 48.7% to 37.6%, particularly low rates amongst persons greater than or equal to 55 years of age. And one of the reasons behind is the epidemic was well controlled during that period, and the number of infections went down substantially from July to September. And that's why a lot of individuals perceive the risk as low at that moment. That's why this is one of the reasons to explain why the percentage of intention to receive the COVID-19 vaccine decreased significantly from because we have done a lot of rounds of survey. Right now we have already completed 9 rounds of recruitment to see how the vaccination intention changes across time. So there are a couple of factors associated with higher tendency for receiving COVID-19 vaccine, were more anxiety, less complacency, more confidence, collective responsibility, and also age is also one of the factors. Compared with person 18 to 24 years of age, senior were less likely to receive COVID-19 vaccine. Although this was a study investigating the intention of COVID-19 vaccine uptake among general population in Hong Kong, this is still useful to help the government to refine their vaccine campaign strategy. So that's why that kind of study can inform the government the concerns of the potential vaccine uptake individuals. Given the challenges of increasing hospitalization under 18s in recent months and the motivations of potential approval for emergency use of Pfizer vaccine on children aged 5 to 11 in the coming few months in the US, examining factors associated with the likelihood of COVID-19 vaccination among primary school students falling into this age group would be very important. So that's why, a few months ago, we conducted an online survey. We approached all 455 public primary school, which accounted for 77% of all primary schools, of which 19 distributed 13,120 invitations and online survey links via the intranet or left lists by school administrators. So the eligibility criteria for participants are, we target the parents. As vaccinating the kids requires the consent from the parents. And that's why parental decision or intention to vaccine their kids would be the proxy of COVID-19 vaccine uptake rate of the primary school students. And that's why our target is basically the parents, not the kids. Okay, parents will help answer the question for the kids. And that's why the eligibility criteria for the participant, a parent of a child who attends a publicly funded primary school in Hong Kong, aged 18 years or above, literate in Chinese, a permanent resident of Hong Kong. We define a subject to be ineligible if they did not meet all of the above criteria. So of course, to compensate their time, those completing the survey were compensated with a coupon value at 10 Hong Kong dollars, which is equivalent to US 1.29 US dollars. Okay, ultimately, we are able to have 349 eligible and complete responses out of 638, because not everyone is willing to answer whole set of questionnaire. And that's why about 300 of them did not complete the questionnaire. So basically, 349 parents completed the online survey. And this is the table showing the study participants' demographics To sum up, parents' mean age was 41.1, and most were female, married, and completed high school, while children's mean age was 8.1, and the range is from 5 to 13, because maybe some of the primary school students are migrated from mainland China. That's why their age is slightly higher than 11 years old. And that's why we obtain some individuals with age 12 and 13. And 55.3% of them were male. So as I mentioned before, we are interested in measuring the vaccine hesitancy of the parents. Okay, that's why the 5 C's questions are the highlight of this study. So you will see we have 5 C: confidence, complacency, constraint, calculation, and collective responsibility. So we have different colors showing the percentage of different levels of agreement to different statements. So basically for each C, we have 3 questions for each construct. Okay, when you're referring to confidence, they are related to the confidence to vaccine, whether it is safe or not, the confidence to effectiveness of the vaccine, and also the I'm confident that public authorities decide in the best interest of the community. Okay, basically the confidence is related to vaccine effectiveness, safety, and also the trust to the public authorities in deciding the best vaccine for the community. So so basically for each C, we have 3 questions. I think we can focus on one color, which is neutral, because we basically use the 7-point Likert scale to measure the level of agreement on each statement here. So you will see a lot of individuals present themselves to be neutral, okay, in different questions under 5 C's. So for example, you will see about 40% of, so am I able to use Zoom to do some drawing? Okay, I can't do anything. Okay, so when you refer to the gray color here for the confidence, you will see the percentage is about 40%. That means very large proportion of individuals are neutral. They don't have any stance on the confidence to the effectiveness, safety of the vaccine. Okay, so imagine you were the government official when you refer to this number. What's your concern? That means a lot of parents are still keeping the wait and see approach for the vaccine effectiveness and the safety. Okay, so that's why if you were the government official, you should think about whether you should address the concerns of the parents. If, as I said before, confidence is one of the strong predictor for the COVID-19 uptake intention in the general community. So, you know, parents are definitely one of the important members in the general community, and their views are likely to affect their decision in vaccinating their kids. And that's why the first thing the government officials look at this diagram, they should be careful why a large proportions of individuals choosing neutral in many constructs, for example, in confidence, complacency, and also some items in constraint, is about 1/3 of them shows neutral to these constraints. Okay, so that's why so you will see some of them some of the items may have a very high level of agreement for example, calculation, you will see the green bar accounts for 70-something%. While for the confidence and complacency, it seems to me that their opinions are very divided. So that's why when you just refer to this 5C construct, you have some idea of the general impression towards the issues of vaccinating their kids. So this is the table one of my published paper, is referring to the factors associated with parental intention to accept the COVID-19 vaccine for their kid. You will see parents were likely to accept COVID-19 vaccination for their child, which is 21.2%, while for themselves is 36.1%. Okay, when you refer to these two numbers, so for themselves, 36.1, for the kid is only 21.2%. There may possibly some reasons behind. You know, in Hong Kong, there are lots of incentives to encourage the adults to have vaccination. And also, there may be some hidden requirement. Hidden requirement means that the employers may strongly encourage the employee to have vaccination, if to make sure they, this is some of the prerequisites for the employees to do before they come to work. Okay, otherwise there will be a lot of requirements. For example, they are required to do the regular test every 2 weeks if you are not vaccinated. And that's why if you go for work, there will be lots of procedures for the testing if you are not vaccinated. So imagine you work and you have a lot of limitations on you, and a lot of employees tend to be vaccinated, so they don't have to do the test regularly. Okay, so that's why this discrepancy is telling you when it comes to vaccinating the kids, even some of the parents may already been vaccinated, but they may not agree their kids to be vaccinated. So this is an interesting result here. And also the second estimate I would like to draw your attention is a children actual flu vaccine uptake rate is 63%. So that's why it seems to me that the parents' impression to flu vaccine and COVID-19 vaccine seems to be very different. Okay, one of the reasons behind is in Hong Kong, we have a outreach program for the influenza vaccination. That means the health authority will assign some staff to do the outreach program and arrange the vaccination, the flu vaccination in school. And that's why the influenza uptake rate is quite high. But for the COVID-19 vaccine for the kids, because right now, COVID-19 vaccine for the kids are not ready, the government may also use the same approach to have an outreach program for the kids, and the percentage may likely to rise afterwards. But at the moment, because we are asking their intention to vaccinate their kids, that's why the number is relatively smaller. Now, the next thing I would like to draw your attention is the factors associated with parental intention to accept a COVID-19 vaccine. They are parents with secondary education or less. That means less educated individuals tend to allow their kids to be vaccinated. This is very surprising because our experience told us that more educated individuals tend to have their kids vaccinated. Unfortunately, the result is completely opposite. Okay. The second factor affecting the parental intention to accept the COVID-19 vaccine is intentions to travel outside Hong Kong. The third factor is receiving the seasonal influenza vaccine. And the last one is not surprising, having confidence in vaccine and authority were more likely to accept COVID-19 vaccination for their kid. So the conclusion from this study, increased confidence in vaccines and health authority was associated with higher parental intention to vaccinate their children, and vaccine skepticism might be related to mistrust towards the government, apprehension about the speed of vaccine development, and doubts about the return to normalcy after mass vaccination. And as I said before, one of the interesting findings is the well-educated parents tend not to allow their kids to be vaccinated. The reason behind may be there might be more sensitive and critical towards the government, and hence more likely to resist their vaccination recommendation. So with the abundant new evidence and divergent comments on vaccine, hesitancy among those educated parents may swing as the pandemic progresses and vary across socio-political contexts. So one of the limitations of the study is the response rate is quite low. And also we have some restricted generalizability of the Chinese literate parents of children who study in public school. Last but not least, about the findings implication, the first one, the higher actual influenza vaccination rate among the children, 63%, may possibly due to the school-based vaccination outreach programs, as I mentioned before, compared to parents, suggested that schools are seemingly viable platforms to promote COVID-19 vaccine for children. So that means in the long term, we hope to get more kids to be vaccinated, no matter influenza vaccination program or COVID-19 vaccination program. School is likely to be a good platform to promote the vaccine for children. Second, countries enforcing COVID-19 vaccine passport might motivate parents who have future family travel plans to vaccinate their children. So to conclude, I suggest some ongoing research should explore ways to improve parents' confidence in vaccines and possibilities of co-administration of both COVID and influenza vaccine in terms of safety, immunogenicity, and efficacy profile, to use more intensive education efforts to encourage educated parents via different intervening platforms and develop secure, standardized, and ethical vaccine passport systems globally. Thank you for your kind attention.
Thank you very much, Dr. Kwok. But I want to take this opportunity to thank Dr. Kwok again. I think your talk provide us, those of us in America, a very good description, not only of the epidemic and also vaccination coverage in Hong Kong and why people choose to take vaccines or not, and whether they intend to have their kids vaccinated or not, but also provide us faculty and students here in the US to understand context matters, especially in terms of vaccination against COVID and a situation in different parts of the world, both the United States, in China, and in other parts of the world. Politics and trust and other things mingles together. And it is our job as public health researchers to understand the context so that we can do evidence-based policy recommendations. So we thank Dr. Kwok again for your time today.
Okay, thank you.
Thank you.
My pleasure.